Thank you, Dr. Sharmishta Mukherjee, for the kind invitation, and to the entire organizing committee for giving me this opportunity to share this special space. It's an absolute honor to be sharing a space with all my teachers today, talking about a very important topic, insulin use in pregnancy, and an update, and an absolute honor to be here on this momentous day to discuss this. I always begin by asking the audience to think about how many pregnancies do you think are complicated by hyperglycemia in our world. And this is data from the IDF Atlas, and there hasn't been too much of change in the last few years about it, but roughly 27% of all pregnancies are complicated by hypoglycemia, and the majority of it is thankfully gestational diabetes. So that is 1 in every 4 pregnancy is complicated with hyperglycemia. I know some of us are probably thinking that maybe this increased prevalence is attributable to the fact that we've been making the diagnosis of GDM extremely easy. We've been narrowing down the thresholds, and we also brought down the number of abnormal values from 2 to 1 over the years. And it could just be that, right? Or is it something else? So before I move on to talking about insulin use in pregnancy, I think it's crucial that we pause to think about this aspect of diabetes in pregnancy itself, because this one particular paper, which got published early this year, set out a conversation on social media amongst doctors and endocrinologists, again, trying to guess or probably pitch the best screening test for gestation diabetes. So this was a large group of people who were recruited as part of a randomized controlled trial, and they were divided into groups of hospitals which followed the 1-step and hospitals which followed the 2-step. And at the end of the trial, they went on to conclude that yes, the diagnosis of gestation diabetes was greater when you followed the 1-step, but they went on to say that there was no between group differences when it came to outcomes, and the outcomes they looked at were perinatal and maternal complications. Now, it's important to think about why we want to make and screen women for gestation diabetes. Is it only for improving maternal and perinatal outcomes, or is it something more than that? We do appreciate that pregnancy is a critical window where we could potentially alter the future metabolic risk of the offspring that is yet to be born. And it's also important for us to be thinking about this in the long term while we talk about diagnosis and management of diabetes in pregnancy. And that's exactly why the conversation about insulin in pregnancy cannot happen without us understanding why we are trying to do whatever it is that we are trying to do when it comes to management of women with diabetes in pregnancy. And we do know that much of the change in the diagnostic criteria happened after the diagnosis of the HAPO study. And this audience does not need any introduction as to how it was done. But it's important to remember that there were close to 15 centers, 23,000 odd women. They eliminated people with fasting sugars greater than 105 and 2 hour greater than 200, and they followed everybody else. And it was blinded completely. And we do know that their outcomes were also related to maternal and neonatal outcomes, and we do know the results. But they categorized women into 5 categories, and category 1 was as low as 75 fasting and 1 hour postprandial of 105. Yet they found a strong continuous correlation between all the maternal and neonatal outcomes that we all know is the primary conclusion of this particular paper. But now what has changed in the last decade is that now we've been able to follow up the offsprings who were recruited, whose mothers were recruited as part of the HAPO study, and probably will now have data on the long-term metabolic outcomes of the children who were part of the HAPO study. And this paper was published in 2019, and probably because of the craziness that took over the world right after the publication, maybe we didn't pause enough to reflect on the findings of this paper, that I thought I should spend the first few minutes talking about this before I go on to talk about the tools that we have to get to this management issue. So this study did a very simple thing. They brought back the offsprings of the mothers who were recruited in the HAPO study, one particular cohort, and they went on to do an OGTT for the children, and they also tried to look at the incidence of, let us say, impaired glucose tolerance or impaired fasting glucose in these children. And what they found was this, that in the mothers who had GDM according to the HAPO criteria, In children who were now aged between 10 to 14 years, the risk of impaired glucose tolerance was about 2 times higher than in mothers whose blood sugar levels were not in the GDM criteria as per the new cutoffs. And the prevalence of impaired glucose tolerance was close to 10.6%. So that is a number which you can't ignore, especially in children aged between 10 to 14 years. You could potentially say, but obesity is rising in children, but even after adjustment for the childhood BMI, the findings were still valid. So that study looked at GDM yes or GDM no, but what about the continuous aspect of the blood glucose levels of the mother and how that panned out? So another paper was again published, which looked at that, a continuum of maternal glucose with the blood glucose levels of the offsprings after they were born. And this also came about that gray area where we were completely distracted with COVID, and probably why we haven't reflected enough on the findings. About 4,000 and odd children were brought in. Again, I want to point back the extremely almost close to normal values of the blood glucose levels. And these are blood glucose values which are still above the targets that we look out for our women who come in for management. And you see that there is a linear correlation when it comes to the child's 1 hour glucose value, child's 2 hour glucose value, in correlation with the various categories of the maternal glycemic levels. Going on to conclude that the maternal glucose levels correlated with the child's glucose values and inversely correlated with insulin sensitivity and disposition index after adjusting for maternal and childhood BMI, suggesting that the GDM that we're diagnosing is not just to optimize this pregnancy, optimize this neonate's outcome. It's also to probably peek through the window and alter maybe the long-term metabolic outcome. So we shouldn't again be having conversations about whether should we do one step or is the 50-gram post-fed state of screening enough or not enough. And from this data, we can now talk about the targets that we'll probably plan to achieve for pregnancies in the future and the new tools that we can use in the form of insulin formulations to reach those particular targets. So how low is a good target to go for women who are getting treated for diabetes in pregnancy? And this is a study protocol which has been published in 2018. This is being conducted in a large group of hospitals in Auckland, New Zealand, where they are trying to look at less tight control and tight control in women who are being treated for gestational diabetes. And if you want the numbers, the less tight is a fasting of 99, 1 hour of 144 and 2 hour of 126, whereas the tight is 90, 134 and 120. And they're trying to primarily look at the gestational age of the child at birth. The study is completed, results are to be out in about 6 months' time. So this is something that we should look out for, because these glycemic targets will be the ones which now dictate which insulin is probably the better option to use during pregnancy. So I think this is the main question of the topic. Which insulin should be used regular? Should we use analog? Which long-acting insulin should we use? Is Degludec a safe medication? How does NPH fare against Detemir? Well, sadly, in this area, we don't have enough evidence to say in the form of a randomized control trial that the analogs are probably better than a regular insulin. But this is the strongest bit of evidence which is available, last published in 2017. There hasn't been a review of this area in the last few years, which tried to look at the best insulin type and the regimen for women who are pregnant being treated for pre-existing diabetes. So this is a slide which is trying to compare Lispro against regular insulin with the outcomes perinatal death and C-section in mind. And you see that there is no discernible difference between the two groups. Of course, the study number is very small. This is a paper which tried to look at aspart versus regular insulin with the outcome of average plasma glucose in the third trimester. Again, no discernible difference. Again, long-acting, Detemir versus NPH, no discernible difference when it comes to major congenital malformations. But you and I, as practitioners, probably have formed some thoughts about how analogs and regular insulin pan out during practice, and we probably are switching up and switching down depending on the context that we are in. But another interesting paper which was published just about 4 months ago was trying to look at, are there various phenotypes in gestational diabetes? Are we able to predict which set of women are more likely to require insulin and are we also able to predict which regimen of insulin suits them better? And this was a paper which was done in Italy, again a review of women who were seen in numerous various hospitals. A good 50% of women were controlled just with diet, but the characteristics of the mother which predicted whether they go on insulin or not was a BMI greater than 30, a pre-pregnancy BMI which was over 25, and also if there was a past history of GDM. So those are probably similar cues that we look for when we're trying to identify women who are likely to need insulin more than women some who might not. And this is again interesting, which was found in the paper. A predominant majority of women were on Detemir alone, and a good, let's say, 20 to 30% on combined basal and bolus, and a very small group on rapid insulin. At least in my practice here in Bangalore, I have very few women on Detemir alone. I probably have most of them on combined. Probably the one very few set of women who probably are only bolus alone. But this is something which was found in this paper, and this is from Italy, which was published. Is Degludec a safer insulin? Do we have lesser incidence of hypoglycemia? There have been case series, maybe about 4 or 5 case series published in the last few years. But these are exciting times again. There is a registered clinical trial called the EXPECT trial, which is trying to look at insulin Degludec versus Detemir together with aspart in pregnant women with type 1 diabetes. And no results have been posted, but looks like they have finished recruiting patients for this particular trial. So we should look forward to this trial, which is looking at the safety of Degludec in this context. We have understood the importance of 1 hour postprandial glucose and its relevance to metabolic outcomes. And there has been a newer insulin, which is ultra fast acting, with a peak which probably coincides best with 1 to 2 hour postprandial peak. And what is the evidence towards this end? This is a case series which was published as an abstract this year from Kolkata, 37 patients, to conclude that 2 people out of the 37 had macrosomic babies and no congenital defects, and overall FIASP was found to be safe in pregnancy. But there is a randomized control trial that has been planned called the COPEN-FAST. No prizes for guessing that it's poised to kick off in Copenhagen, trying to look at insulin FIASP versus insulin novorapid in women with type 1 and type 2 diabetes during pregnancy and lactation. They plan to use CGM at 3 points during the pregnancy to try and look at the birth weight of the children born after adjusting for gestation age. So this is again something we'll have to wait and see. What about pumps in CGM? Has there been any new evidence to suggest pumps will do better, or whether we should begin using CGM more frequently than SFBG? This is again an abstract which was published this year. But sadly, although pumps, we would expect that they should be the better tools that we should use in this context of pregnancy, the benefit offered by pumps in most studies, at least the ones which are looking at type 1 women, have been quite disappointing, that there was no significant difference in infant birth weight as observed in this particular study which looked at women with type 1 diabetes. But when you're looking at continuous glucose monitoring, there is some evidence as per this systematic review, which has looked at quite a few studies which have explored CGM in GDM and no GDM or type 1 diabetes versus SMBG, and concluded that maybe this is a superior tool, especially in detecting hypo and hyper, the fluctuations, and also glycemic variability seems to be better in mothers who were on a CGM, irrespective of the insulin regimens they were on. So continuing with the concept of CGM in pregnancy, so the CONCEPTT trial was another paper which was published recently, which looked at women with type 1 diabetes, aged between 18 to 40, but they were on both pump and multi-dosing of insulin, with CGM studies done at 3 points during pregnancy. The first point about pump versus MDI, notice that at 24 weeks, individuals who were on pump had blood glucose levels slightly higher, and they spent a greater percentage of time in higher sugars than women who were on MDI, although it did get evened out further down the pregnancy. But about 24 weeks, people on MDI were probably doing better according to this trial. And when you look at women who had large for gestational age babies and who did not have large for gestational age babies, notice the difference. The difference is between 7.3 to 7.9. So looks like these small delta variations of sugar are making a huge role in terms of outcomes, and this is something that we must be aware of as we have more and more women tending to have some form of dysglycemia during pregnancy itself. So in this paper as well, they did conclude that women in pumps had poorer neonatal outcomes than women with MDI. Exactly what the reason is, probably we're not really sure. Probably glycemic target, tightening it and getting it down closer to normal levels is probably a little bit more difficult with pump for reasons I do not understand. What about closed loop insulin delivery during pregnancy? And this is a slightly older paper published in 2016. It was an RCT crossover, looked at closed loop and sensor augmented insulin pump. Went on to conclude that women who were on the closed loop therapy did tend to be in range for a longer period than people who were just on sensor augmented pump therapy. Of course, it's important to remember that closed loop therapy is still tricky, is still something which is done by patients. Of course, this was a trial in which the algorithm in the computer was probably a validated one, but in our clinic, you and I, if we are going to see somebody who's on closed loop, it's probably going to be something that they've figured out and fixed by themselves. So that is again something that we'll need to think about, whether it's safe to continue in a vulnerable window like pregnancy itself. So quickly to summarize, hyperglycemia in pregnancy is extremely common in Southeast Asia, affecting 1 in 4 women. It's a critical window. We are not just looking at improving pregnancy and neonatal outcomes. We're also looking to improve metabolic outcomes for the unborn child or to be born child. The cutoffs for GDM correlate very well with long-term follow-up of glycemic levels of children born to mothers. So we should not be second guessing ourselves about the cutoffs for GDM and think that if we should maybe abandon the 75 glucose and go back to the 1 hour post-fed. The targets for glycemic control in pregnancy, we will probably get this data very soon in the next 6 months' time, and that should probably be able to guide us to decide what kind of trials we'll probably design to understand better if analogs are better than regular insulin. And I think the results of this trial is crucial in deciding that. Up to 50% of them might not need insulin. It's important to know that, and not all of them need the basal bolus 4 pricks per day. That is something we need to look at. The newer insulins are being studied, and probably the results will be out very, very soon. Some evidence this year over all the other years to accumulate to say that CGM is probably a better method of monitoring than over SMBG. Pump has sadly not demonstrated amazing benefit over multiple doses of insulin, so it still remains the standard of care. And closed loop pump is a call that you'll probably need to take individually for your particular patient. And this is a declaration which I found when I was looking up to make slides for Professor Chowdhury's talk way back in 2012, the St. Vincent's Declaration, which was done in 1989, which said it was a declaration to say that they will work towards improving pregnancy outcomes of women with diabetes to the level of those of women without diabetes within 5 years. And it's been a solid 30 years since then. And we should now probably expand our vision to say that we want to improve not just the pregnancy outcomes, but also the metabolic outcomes for the children itself. Thank you so much for the honor. And I hand back to our chairpersons.